Hello, and welcome to our webcast. I'm Jamie Pennington with Moss Adams, and I'm getting us started for today's session, Price Transparency, Comply and Flourish Under the New Rules. Before we begin, I'm going to play a brief housekeeping video.
Welcome, and thanks for joining. We're pleased to present our continuing professional education webcast series. Before we begin, please keep the following in mind. You can customize how you view our presentation and interact with the presenter. For better viewing, close all other applications and turn up your speaker volume. You can adjust window size and placement or enter full screen mode using the controls at the top right of the window or dragging the bottom right-hand corner to resize. At the bottom of your screen, you'll see a series of icons that relate to a different aspect of our session. You can download a PDF of today's slides from the Slide Deck and Handouts widget. You can ask questions by typing in the Q&A window and clicking Submit. We'll do our best to answer all questions or follow up via email. If you experience technical difficulty, refresh your browser by hitting the F5 key. Today's session offers 1 CPE credit. To receive credit, you must meet the National Association of State Boards of Accountancy requirements. You must attend at least 50 minutes of the session and respond to at least 75% of polling questions. To participate in the polls, please check the button next to your answer within the slide window and click Submit. We'll track your progress and alert you when you've earned CPE credit. You can then click the certificate icon in the CPE Progress widget and download your CPE certificate. Don't worry if you can't download your CPE certificate today. We'll email you a copy in 2 weeks. If attending this webcast in a group, you must complete our group CPE attendance sheet, available in our Slide Deck and Handouts widget to receive credit. Please have all group members sign it and send only 1 sheet per group. CPE credit can only be awarded to participants registered as themselves and isn't available for participants who view the on-demand version. This presentation is not legal, investment, or accounting advice. We encourage you to seek the counsel of a professional service provider to apply this content to your specific circumstances.
And now I would like to introduce today's presenters from Moss Adams, Riter, Director of Revenue Cycle, and Mandy Mori, Senior Manager of Revenue Cycle and Strategy. Their bios and contact information are located in your webcast console for your convenience. And now I'd like to turn over the floor to Mandy. Mandy?
Good morning, everyone. On today's agenda, we will look at the enforcement activities in the price transparency space and how CMS is pushing for more consistent data. We will cover the major changes in 2024 OPPS rules, discuss the interaction between price transparency and No Surprises Act, and how we view price transparency as a patient-centric strategy. This is state of affairs in the public eye. The social media influences enlisted by Price Transparency Group power to the patients, pressing hospitals to oppose actual costs and be compliant with the regulation. Coincidentally, Richard, my co-speaker, took a photo in passing of the artwork by Shepard Fairey, found in Seattle city streets, demanding for prices as patients' rights, sponsored by the exact same patient advocates group. We have newscasts reporting on compliance and the articles published about how price for hospitals in commercial health plans are double of those for MA plans. So for those of us in the industry, this is simply obvious, right? In terms of the pricing for commercial health plans doubling those of our MA plans. But it might have struck a jarring note to the general public reading this. The message to take away is we have an opportunity to get in front of the movement and educate the public instead of letting inaccurate information be disseminated. Price transparency is beyond a data exercise that your billing office manages. It needs to be a strategic priority to define the healthcare consumer experience provide clarity and enhance the public trust and confidence in providers, hospitals, and health systems alike. I'm going to pass this back to Richard to talk about the current rules and the enforcement activity we've seen so far.
Richard, if you can hear me, I think you're on mute.
Let's see. Are you able to hear me? Oh, there we go. Okay.
Yes,
excellent.
we
Thank
are.
you. Not sure what happened. I just had to reset the connection here. So thanks, everybody. I will start. Did you guys hear any of that at all? Should I start at the top? All right, I'll start at the top. Thanks, everybody, for joining. And if you do have questions, please drop into the Q&A. We will address as many as we can. So the history of price transparency goes back a number of years. It starts with the ACA, and which is 13 years ago now. And there was language in the ACA that said that U.S. hospitals had to make public a list of the hospital's standard charges for items and services posted by the or provided by the hospital. And for most of us who've been in healthcare for a long time, we read that language and we don't necessarily think about payer-specific prices. We think about charges on the charge master and things like that. And I think that's part of what drove a lot of the judiciary activity, a lot of the court activity that we've seen over the last couple of years on this, has been that question about exactly what we mean by standard charges and whether CMS has the authority to do this. There are also some judicial activity around the First Amendment, actually kind of the principle that these prices are a trade secret. So that was kind of the first chapter of price transparency that went really up through 2020, up through 2021 as well. As we moved into 2021, then we got to the fact that that there was some compliance that began, and hospitals really started to post rates. There was a fairly low penalty at the time of $300 per day. Let me go back to my notes here. And CMS actually started assessing a lot of these penalties, prompting a lot of hospitals to start fully disclosing rates. The other challenge, as users started trying to aggregate MRF files across providers, is that CMS initially allowed for a lot of flexibility in file format. And so there was a big lack of comparability. One of the things that we're seeing here is kind of the three themes from CMS is kind of increasing enforcement, increased data consistency, and then standard formatting. So that's kind of the theme we're going to see throughout. I will pause here and see if we have any questions. All right. So a summary of the current rules. So the current rules, we've got a couple of different requirements. The first is the machine readable file. And we're going to spend most of our time on that machine readable file. It's really pretty simple in terms of the actual requirements today. There's the data components. You can see the fields listed there. I'm not going to go through those. And then the file name. And oddly enough, it's been the file name that's actually messed a lot of providers up. We've had more conversations about file name than I ever expected over the last couple of months on this topic. And then in addition to that, which we're not going to go into detail here on this call, is the consumer-friendly format. So either have to have shoppable file posted or a patient estimator tool that has at least 300 services and actually goes down to self-pay cost. And then there's some details around posting. So it has to be posted on the website in a prominent manner. It has to be digitally searchable. Originally, some providers had put some coding on their website that made it so, like, say, Google and others didn't index their websites. And so if you searched for a given hospital and price transparency, it wouldn't come up. It has to be free of charge. It has to be accessible without registering, setting up a personal account or anything like that. And then it has to be updated annually. There's no requirement in terms of exactly what time of the year it has to be updated, but it has to be on at least an annual basis. And we're going to spend a little bit of time here now talking about some of the issues that CMS and others have identified. Some of these are in some of the letters that CMS has sent to hospitals. Some are in some of the third-party organizations that have been reviewing compliance, and some are just kind of our experience working with providers. So the first is around completeness. And so in some of these cases, we've got payer-specific values in the MRF that aren't being populated. And CMS is kind of questioning, is that because either they're not being provided, or is it they're being provided but just not being included? And so that's kind of a clarification that a lot of hospitals have had to deal with. And the next one is around cash prices for some procedures, just the fact that not all of those are being included. Some major payers are being excluded in some cases. So CMS has actually started looking for the major payers in a given market. So obviously, United, Aetna, Cigna, Blue Cross Blue Shield, those kinds of payers, and just making sure that you're including those in your MRF files. And then the last one here is related to completeness, is excluding some procedures that are known to be provided based on public Medicare data. So again, CMS is actually going to look to make sure that you have a relatively complete file from the perspective of the services that you're providing. The next category is the patient estimator tool. So we have some where we're not actually calculating patient liability. So we're calculating just like the allowed amount. It's not getting to that patient liability amount. Then in other cases, it's not including all the required procedures for the patient estimator tool. And then some other kind of miscellaneous things, we're misnaming files. I mentioned that one before. There's actually quite a bit of that going on. In some cases, we don't have a date indicating the most recent update to monitor whether you're actually updating it every 12 months. And then in some cases, we don't have any payer-specific information at all in the MRF. So it might be just basically CDM information, or it might have min-max, but not actually payer-specific information. And with that, Jamie, we'll pitch it over to you for the first polling question.
Thanks, Richard. This is our first polling question. How confident are you with your current compliance approach? A, we have already received a warning letter, but we're able to resolve the issues. B, we have completed internal audit or external review of our compliance. C, we have ample expertise to feel confident. D, we're doing our best. Or E, not sure. We'll give you a few moments to respond. To respond, please click the radio button next to the answer you choose and hit submit. If you can't see the submit button, you'll need to enlarge the slide viewing area. We've got about 2/3 of the audience that has answered, so we'll give it a few more seconds to get your answers in. And with that, here are your results.
Looks like most are doing their best or not sure in terms of compliance approach. Hopefully with this webinar that we will actually help increase your confidence level in terms of your compliance approach as we continue to talk about No Surprises Act and price transparency. So in this, on this actually slide, we're just going to highlight some of the challenges that exist today. There's no standard format for machine-readable files, MRFs, as we know today. While CMS recently released version 1.1 of the voluntary MRF sample formats, which accompanied by a comprehensive data dictionary, hospitals at the end of the day are not required to conform to the template. Another area of challenge is related to the ambiguity in terms of the term payer-specific negotiated charge. So it's been defined by CMS as the reimbursement rate that the hospital has negotiated with a third-party payer for an item or service. What is unclear is today, these rates as required by CMS, are they derived from claims? Are they derived from contracts? So we see a combination of both methodologies used by providers today. Another area that has posed challenge is under current rules, there's no materiality threshold to disclose payer-specific rates. If a contract exists, it must be disclosed under current rules. So while that may be only 2 patients per year for that one small payer, and the information probably would be rather insignificant, it really doesn't matter. If you don't disclose, you definitely have breached the rule or is in violation of the rule. So one of the things that definitely, when it comes to smaller contracts, is there's a possibility that the information may or may not be updated actually regularly because a small contract, it may not catch the eye of the administration. So this is definitely an area of concern for some where you can easily kind of find yourself in violation. Last but not least, I want to bring up is about communication. So currently, notice of warning sent by CMS is attention to the CEO of the hospital. So we know CEOs are extremely busy, and these warning notices may take a while to really trickle down to the appropriate person to take action and respond. So all this means is basically getting more delays in getting these addressed as timely as one would like. So on this slide, you can see here, there's actually a significant increase in compliance. So 43% increase really in hospitals meeting 100% of the display criteria since inception of the regulation. Conversely, you can see a significant decrease in those not meeting the requirements at all. But that just as we are settling into meeting the display criteria, right, over the last 1.5 years, 2024 is upon us with major changes that Richard will cover shortly. So on this slide, you can see here through September 2023, which is this month, 13 hospitals have been fined by CMS with price transparency violations, totaling about $4.5 million in violation fines. The most recent fine of University of Florida Health North, which is a 92-bed hospital with a full service emergency room, pretty busy emergency room, about 40,000 visits last reported in 2022. So with the new rules being codified and stricter enforcement, we expect the penalties to really continue as we're all trying to acclimate to the new rules that Richard will now cover. Richard?
All right, thank you. And hopefully the technology works out. I had a second where I wasn't able to even see my screen the last go around. So hopefully it all works out. I'll cross our fingers here. Hopefully you all can see me and hear me. So wanted to spend a little bit of time just kind of thinking big picture about the new regulations these are proposed rules. So this rule was put out in July. We'll see what the final looks like here in November. But we want to remember that the goal of CMS is to get data that's available in the public domain so developers can use it to create tools that facilitate patient decision making. It's not really for patients to look at directly. And I see some questions in the Q&A on this topic, and that's something I've had a lot of discussions about in terms of patients themselves getting into these files. That's really not the goal of CMS. one of the approved formats is the JSON format, which is not really accessible to most people. And so I think that's how we need to be thinking about this, is that this data is meant for tool developers and data aggregators and things like that. So I think the thinking is that with so many patients exposed to provider reimbursement rates based on coinsurance and deductibles, if patients have this information, then they'll actually be able to put downward market pressure on provider reimbursement rates. I think CMS also expects downward pressure on rates from payers and employers having this information, which of course is not great for providers. So that's something I think as a provider community, we need to keep an eye on. As we mentioned, there appears to be kind of broad compliance at this point. So initially it was not a lot of compliance. We're seeing a lot of compliance now. And some developers have started trying to make tools that show comparisons among hospitals. The files are currently not really consistent enough to make comparable data. So there's a lot of apples and oranges going on. I think that will change under the proposed approach for 2024, where the proposed rule will require files be produced in a way that's not only comparable among providers, but also really shows kind of the guts of your contract. So the detailed calculations, the logic, and things like that in your contracts. And that's going to let them make tools that can actually produce actionable information for patients. They've got 5 proposed formats that they've looked at based on service type. We've got 2 of them here on this sheet, and this is not the full template. This is really just the pieces of the template that would change. So you can see the top one there is for per diem data, and you can see kind of the level of detail that they're looking to get to. So in that top example, so you can see this example, you'd have a per diem where days 1 through 3 are a given rate, days 4 through 7 are a different rate, days 8+ are a different rate. And so they're actually looking for kind of that level of detail in the files, not just to say, overall for a given payer, my average per diem rate is X. So they're kind of looking for the kind of internal logic. And you can see on that second example there with an implant carve out, they're kind of looking for kind of what % of implant costs and that kind of logic to be included as well. And, the way I'm looking at this is right now, as I look at, files that are public out there, I see kind of 3 basic compliance approaches that providers have taken. I see kind of a charge master line item approach where providers take kind of what they're getting reimbursed and spreading that back to the charge master line items. I see, standard grouping like by MSDRG and APC or something like that, again, based on actual reimbursement rates. And then I see somewhere we actually are taking payment terms and applying those as well. And I think part of the challenge that we're going to get here is that, what CMS is proposing is it's most similar to 3, which is actually taking the specific payment terms for each contract. But they are looking for providers to include a patient-friendly allowed amount in there as well. So they're kind of taking a bit of both, and that's going to be pretty complex to knit that all together. All right, Jamie, our next polling question.
The second polling question is, how complicated will it be for you to implement the proposed templates that incorporate specific contract terms, expected allowed amount, and other elements such as drug units or type of measurement? Your answer choices are A, this will be a big lift since we have a lot of competing priorities. B, we're already looking at it and it seems doable. C, we'll be working with our existing vendor to think through this. Or D, not sure. You do have the option to submit questions for the presenters in the Q&A window. We have quite a bit of content to cover today, so if we don't have time to respond during the webcast, we will follow up with you afterwards. And as a reminder, if you would like to receive CPE credit for today's webcast, you will need to respond to at least 3 of the 4 polling questions, and you'll need to do so by selecting the answer in your slide viewing area and hitting submit. We'll give it a few more seconds. And here are your results.
All right. So, yeah, it looks like it's going to be a big lift for a lot of folks. There's a lot going on. And I think there's a lot who haven't really looked at it yet as well. This is still new. And of course, we don't have a final rule yet, so that makes it more of a challenge as well. All right, let's see. So I think, let's see, is this you, Mandy? Oh, this is me. So with the proposed rule, so CMS is looking to improve communication and hold providers accountable here. And the first way they want to do that is through certification. And one of the things that they're looking at doing is actually requiring submission of certification by an authorized official as to the accuracy and completeness of the data in the machine readable file. And part of the reason for doing this is I think when CMS has issued notices to providers, one of the things they've come back and said is, well, this is basically complete or it's not complete. There's that kind of first step around kind of are you kind of asserting this is complete or not? And they're trying to cut that out of the process. And so that's really the first one. The second one is around acknowledgement of warning notices. And as Mandy mentioned, these are going right now to hospital CEOs. Hospital CEOs get a lot of mail. A lot of it's not like this. And so they aren't always making it to the right place. And so that's the first step they're wanting is just acknowledgement of the warning notice. There has been a little bit of, kind of the dog ate my homework kind of stuff where these things just get lost. And that's, in some cases, that's been kind of legitimate and true. But CMS is trying to kind of cut that out of the process. And then the communication with health systems. So right now, in order for CMS to work with someone at the health system, if a hospital is part of a health system, they actually have to get a letter from the hospital CEO authorizing them to do that. And my understanding is that CMS doesn't feel like they have the authority to talk to the health system folks about it without that letter today. And so they're looking to change that through rulemaking here. And then the last one is publicizing compliance information. So right now they only publicize it if they're kind of determined that you're out of compliance and they're starting to impose civil monetary penalties. They're looking to change that and to really kind of back that up. And so a lot of additional compliance information would be released if this were to go through as it's currently written. And I see some questions in the chat here around kind of is CMS actually reviewing these files and things. And so this is that information about kind of what CMS's current audit approach is. So as of April, they've updated their approach. Before that, they were looking at about 30 or 40 websites a month. They're now looking about at least 200 a month, they're saying. So put that into context, there are about 7,000 hospitals in the country. So they're going to get to, about a third of them or so on an annual basis with this new approach. And you can see the timelines there. I'm not going to go through all that in detail, but the point is they're really trying to speed that up. And you can see on the bottom there now, so through April, they actually had 730 warning notices that have been issued, which is a lot considering they were only doing 30 or 40 reviews per month. So a very high proportion was getting warning notices, and actually quite a few of those were getting corrective action plans. And then here's just an example of one of the initial hospitals that received civil monetary penalties and what the timeline looked for them and what it looks like under the new timeline. So under the original timeline, Northside Atlanta, which is one of the initial hospitals that got civil monetary penalties, it took almost a year to get there. Under this new timeline, if CMS determines that you've not made an attempt to satisfy the requirements, so you don't have the files kind of out there and it looks like you're trying to comply, they're going to do it in about 3 months. So a pretty quick turnaround to get you into fine territory. And I think that's, when we showed the fines a couple slides back, I think that's why you're seeing a lot of those happening here more recently, is because they've decided this is really kind of an urgent issue and they're pushing that timing a lot now.
And Richard, before we go to the next section, I know there's a question related to the anticipated date for the final rule. My understanding is that the actual public comment period has just ended yesterday, and the final rule should come out sometime in November. Is that correct?
Yeah, so I think that's right. I think, the comment period was through, I believe, yesterday. Normally, we would expect OPPS final rule to come out right around like Thanksgiving. Or I'm sorry, not Thanksgiving, Halloween rather. Get the holidays right. So around November 1st or so. So that's when we're expecting to see it.
So in this section, we'll cover just the ecosystem that is kind of like budding and forming with the integration of price transparency and No Surprises Act. So we see the formation of data aggregators and tool developers, as Richard talked about earlier. They're aggregating and digesting hard to understand machine readable files. So employers, payers, providers, consumers, lawmakers, a part of this ecosystem of information speedway, I call it. And all of them will be playing obviously a key role to shape price transparency and No Surprises Act. So in this slide, it's quite busy, but the message we're trying to take away from here is that self-insured employers, have generally leaned on health plans to manage their benefits, pricing, provider networks, and claims in the past. So hospital disclosure data now really empowers the employers to easily compare the negotiated rates with those of other insurers of the TPAs contracting with the same hospital, as well as charges and cash prices, solely determined by the hospital, right? So price transparency really inform them of the actual prices. I think potentially incentivizing them to move towards, exploring direct to provider contracts from an employer perspective. So we're looking at price transparency, obviously maybe leading to a price war amongst commercial health plans, where prices are really going to be used to undercut the competition. So today, price estimates, or we call it good faith estimates in the No Surprises Act terminology, are provided only to uninsured or self-pay patients. And we do expect that pressure mounting from all fronts to really make price estimates available for all in the future, self-pay, uninsured, and insured population down the road. Another thing that we were thinking about coming out of this ecosystem with more information being made available is that we already see a lot of shift from a site of care from inpatient to outpatient. And we'll anticipate that higher margin outpatient services, including basically services performed at an ambulatory surgery center, will start to expand and really accelerate, over the lower margin inpatient care. So this movement is not going to stop. The other thing is that I think it's an important message to take away too is that price, we know, is not the only thing consumer look for when they're choosing care. So linking prices to quality and outcomes data upfront, identifying high value services, not just lower cost healthcare, will become a really important message. So these are the things that we feel will be actually transforming over the next few years. With that, quickly we come up to the third polling question. So I'll kick it back to Jamie.
Thanks, Mandy. The third polling question is, have you started integrating the impacts of price transparency into your strategic planning process? And your answer options are A, yes, we've incorporated impacts of patients driving site of care changes. B, yes, we've built in impacts of changes in payer behavior and reimbursement. No, we need help thinking through this. D, we haven't thought about it yet. Or E, not sure. For those of you that would like a copy of today's slides, you can download them from the folder that says Slide Deck and Handouts in your console. We will also be sending the slides via email tomorrow, along with a recording of the webcast. We've got about 2/3 of our listeners that have answered, so we'll give it a few more seconds.
Richard, there's a question about whether this new requirement applies to community clinics as well. I presume the new requirement they were referring to is the 2024 price transparency requirement. Any thoughts about that?
Yeah, thanks, Mandy. So the current rules apply to anything that's hospital licensed by the state. So it applies to normal hospitals, critical access hospitals, et cetera. There is some legislation that's currently being considered by Congress that would expand that to include health centers and ASCs and things like that too, but it's not currently the requirement.
Okay, and with that, here are your results.
So majority of our audience here answered not sure for incorporating the impacts of price transparency in the strategic planning process. And I don't believe that is really surprising to both Richard and I. So as we stress that the price transparency, No Surprises Act really should be a strategic priority and should be incorporated into the strategic planning process. So it's really, again, not a data exercise, not something that relegates to your billing office to manage. But we do have some that have thought about and built in the impact. So kudos to you all who have already started doing that. So we know U.S. healthcare prices have historically been anything but transparent, right? So the NSA price transparency regulations were intended to correct this information void. So, Richard and I were talking about, decisions are being made nonetheless, right, in this information void in terms of pricing, whether a patient actually knows what they're going to be receiving in a bill as far as medical expenses go. So at the end of the day, information is not at the best available to all the parties previously. And the intention of the act, again, is to correct that void and give more information to make informed decisions. But we know that payers and providers continue to grapple with the implications and the implementation of both rules, as we saw in the previous poll. So the dynamics between the payers and providers have really changed, with the implementation of both NSA and price transparency. Information now is out in the open. And some will argue that it's really not really out in the open because the complexity of those machine readable files, where it is really not, intended for human to read, really is really not that clear to everyone reading and trying to get information about pricing. But at the end of the day, I think there is definitely momentum for payers, providers to really rethink contracts, negotiation strategies, ways to build trust with the consumers, basically the patients who are the healthcare plan members. So payers have the power of information to put a downward pressure on provider rates today. Combined, the rules of No Surprises Act and price transparency, points to defaulting to a qualifying payment amount, which is what we call the QPA, which has been argued as being really favorable towards payers, and obviously in litigation, and so No Surprises Act definitely is still in flux. We have a lot of litigations that have not been resolved. There's been several rulings from Texas courts, that have definitely changed some of the provisions of the act. But at the end of the day, there is value from both of the acts together. But again, we feel that it is definitely tilted right now towards the payer more than the provider. But over time, we're hoping to see that kind of balance being corrected. And one of the things that we thought will be really important to stress is that there is a requirement for network adequacy from No Surprises Act. And I was telling Richard, like, from my perspective, is really about network transparency, which is, again, the interplay of transparency and the No Surprises Act, is that the network transparency hopefully will actually become more prevalent in the future, where it is not just about how big your network of physicians is the quality and the type of physician, in the network. And that will become more important. And I'm sure that will become more refined over time. So we're going to actually talk a bit about how price transparency is really a patient-centric strategy. So you see here this pyramid, and the pyramid being the bottom of the pyramid, which is what we expect. We expect, the government expects, CMS expects compliance with price transparency rules and the NSA. So again, we in a fee-for-service industry, right? When you're talking about driving down costs, empower consumers, transparency mandates are really making hospital and healthcare leaders consider how competitively advantaged you are and what steps you really need to be taking to become better and more patient-centric, to really put a stake in your market share, increase your market share, not lose market share because of these rulings that have come out. So from our point of view, and in working with our clients, organizations that really embrace the intent of the legislation will capture the market share by really climbing the pyramid, as you see here. So at the very top of the pyramid are those who really dedicate their efforts to increase patient engagement, provide accurate patient specific out-of-pocket cost information, and couple them with information on quality and outcomes. So as we were talking about this is, goes back to the triple aim, right? We're talking about the price, we're talking about the experience, we're talking about the quality of care. So, studies have really shown that people who are aware of the costs are likely going to consume the product or the service. So I think about like the Uber of today, right? And you think about booking a hotel, booking a flight, that you have all the information necessary, that you are going to pay this exact amount when you go in and you leave. So people show up to basically a service more likely than not. So patients in that sense who understand the cost of care are more likely to really be more satisfied with the care. You probably have less bad debt, and therefore like translates to less of collection costs for providers and the hospitals alike. So providers and payers alike really need to think about their operational readiness for the law. Consumer outreach effort is going to be key, and how do you actually enter a negotiation? So it goes back to pricing. While it's an element of basically your strategic approach, it is only one element of a multiple variable, like a multitude of variables to determine your market position at the end of the day. So again, driving home the message that this is a strategy, not a tactic, and not really, the daily chore that you have to kind of work on to make sure that you're compliant. That should be the most basic thing that we are looking at, and we need to kind of rise above all the noise and become more strategic. So with that, I'm going to go into the fourth polling question and turn it back to Jamie.
Thanks, Mandy. This is our fourth and final polling question. Have you laid out a multi-year plan to become more patient-centric? Your answer options are A, yes, we're on track to meet our goals. Yes, but our execution has lagged. C, we're working on a plan, but the moving parts are making this really complex. D, no, we haven't started yet. Or E, not sure. Once you have completed all CPE requirements, you will be able to download a PDF of your certificate from the CPE progress window. Also, at the end of the webcast, a survey link will appear. We'd appreciate any feedback you're willing to share, and we'll use the information to develop future webcasts for you. We'll give it about 10 more seconds to get your answers in. And here are your answers.
Yeah, thanks, Jamie. Yeah, there's no doubt about it. This is complex work, so we're seeing a lot of that reflected here. And before we get to some of the next steps here, I did want to address some of the questions that are in the Q&A also. And so one question is around antitrust concerns, and if there are antitrust concerns about using other price information. And our understanding is there are not antitrust concerns. This is all in the public domain, and that's kind of available for use in whatever way you kind of deem fit, is from a negotiation standpoint and things. There's another question around the physician piece of it and incorporating professional fees as part of the estimates and things. That's a great question. That's a really important topic as we're trying to make this all work better for patients. And a lot of that functionality is going to come through the No Surprises Act. There's a provision of the No Surprises Act for advanced EOBs. We're expecting to see regulations around that, and that's starting to roll out next year. There's still a lot of rulemaking that has to happen to make that work. So I think there's a question mark. I think probably CMS is delaying some of it based on all the pending litigation and things here. So we'll see how that works out. But that will be in the works, and that will be the mechanism for it. It will be through the No Surprises Act. And then there was another question around, does this apply to new hospitals as well as existing hospitals? And there's not a separate requirement for new hospitals. I think generally, because they're landing on the side of requiring that this is based on contracts as opposed to kind of the net reimbursement rates you're seeing in claims data, for the most part, this isn't reliant on having historical claims data to do these calculations. The one exception to that, I think, is that that patient-friendly allowed amount, which is going to be a little bit tricky to do without any paid claims experience at all. And so I think that's something where you need to kind of work through a couple options and figure out the best way to do that. But our understanding is the requirement does apply to new hospitals as well as existing hospitals. And then there were a couple questions around timing. We talked about the timing a little bit previously, and we've got some information here on this slide as well. And I think, you know, that's really, really important. That's I think, a big concern for all of us. Normally we see the OPPS final rule come out at the beginning of November, like we talked about. They have said that they're likely to give an extra 2 months before enforcement begins. They're not required to do that, and so we don't really know for sure whether that will happen or not. And it could be longer than that too, because this really is just incredibly complex change that we're looking at. So there's a lot of question mark around exactly when this will end up being enforced. But it could be as early as January. It may well be March, and it could be later than that, and we won't know really until November. And so, you know, that really gets to our first point here around what people should be doing now. You know, providers should be starting to prepare for those price transparency changes now. Again, there's a lot of uncertainty about when it'll be required and exactly what it's going to look like, but I think we see the general path, and it's going to take a lot of work to get there. The next one is around cost information. So we want to make sure that we're setting up ourselves as providers for sustainability. And it's tough to do that when you're looking only at the revenue side of the equation, right? We need to be bringing costs in here as well. And I know a lot of providers have challenges looking at cost accounting information, but that's just such an important part of this that, you know, if you need to go back and improve some of that cost accounting information as part of this, I think that's really a worthwhile endeavor too. And then starting to evaluate your position in the market by looking at outcome and patient experience data, like Mandy talked about, you know, the triple aim, right? We've all been talking about the triple aim for years. But I think, you know, the goal here really is to not let this conversation be purely about price, but to incorporate the other two legs of the triple aim as well. And then there's that traditional and non-traditional market participants, you know, so we're talking about in a lot of markets, we're seeing, you know, for-profits and others coming in to take some of that market share from traditional players. And a lot of times that market share they're taking, you know, I hate to say it, but, you know, it really is kind of the most profitable part of the market. It's going to be, you know, your commercial payer mix and you know, leave traditional providers with the less profitable, you know, the Medicaid and the other pieces of that payer mix that, you know, providers are there and a lot of times to serve those, you know, those markets and those communities. So that's a good thing, but we need to make sure we've got financial sustainability to do it. You know, so those things really should happen kind of starting now. And then, you know, over the next 3 to 9 months, you can see some of the things we're suggesting there, you know, really starting a rationalization process, looking not just at your charge master, but also what your payer contracts look like. And then looking at, you know, provider entities and venues of care as well to make sure that you've got kind of rational prices between your acute care hospitals, say, and your ASCs and other venues. And then the last thing there for the last 9 to 18 months would be, you know, looking at moving from non-binding estimates to firm package pricing for shoppable services. I think, you know, when we look at what the advocates are pushing for on this, you know, initially when there was really not a lot of enforcement and not a lot of compliance, we were seeing the advocates pushing for just, you know, get files out there, right? And that was the first step. And that's now largely happened. And so kind of what are they pushing for now? They're pushing for firm estimates of the package. And so that's likely to be the next thing that we see a lot of movement around. And then the next thing you can see is looking at patient liability impact on population health and value-based contracts. And really the point here is that so many times in the past, we've been working with payers on these things, you know, we're only looking at the health plan impacts. We're not looking at the patient impact as well. And because of the fact that patients do have so much skin in the game now, we want to make sure that that's a part of all of these conversations that we're having with payers. And to the extent we can kind of shield, you know, patients from some of the impacts of things, you know, we want to be doing that and make it be kind of as patient friendly as we can. And the last thing you can see there for the 9 to 18 month timeframe is engaging with patients and consumers using pricing as a vital element. You know, if we look back at that pyramid that Mandy just walked us through, you know, that really is, you know, kind of as we're walking up that pyramid, that's really an important part of that. Pricing is not the only element, and it shouldn't be even the primary element, but it needs to be, you know, one of the vital elements of how we're engaging with patients, along with, you know, patient experience and quality and things like that. So, you know, I think that's kind of what the plan should be. I'm just looking to see if we have any other questions here in the chat before we move on.
Richard, I was just curious your thought about the size of the hospital when they're being penalized. So a lot of the fines have been kind of issued towards regional hospitals.
Yeah.
Do you feel that size is a matter when it comes to like CMS attention to which hospitals they're going to be looking into?
Yeah, and that's a great question. And so I think size is probably not a part of how they're selecting hospitals necessarily. The fines themselves, the penalties are indexed based on hospital size, so it does come into play there. Our understanding in terms of how CMS is identifying hospitals for review is some of it is random, but there are other pieces of it where they are actually looking at some of these third-party advocates and seeing what they're claiming are non-compliant hospitals, and they're actually targeting some activity toward them as well. So, even though some of these other third parties are not authoritative and don't necessarily use the same criteria that CMS is using in their reviews, it is something that you want to take a look at because CMS also looks at them for targeting purposes.
So there's a question in the chat or in the Q&A about with everyone required to post negotiated prices, there are no longer any issues with antitrust because they can now see how all payers are paid by providers are paid by payers for the same services, plans, and products. I mean, I know we're not legal; we can't provide legal advice. I mean, I was thinking about from my perspective. I mean, it really just enhances, the message that, because price is only just one element, that price cannot be the only consideration. So that becomes a competitive disadvantage if price is the only element. And goes back to the strategy of incorporating your outcome. How are you better as a provider to really negotiate a really good, fee for your service versus using price as a competitive advantage as we did in the past when prices were more opaque, right? They're not really visible to others. So, but again, we're not legal, so we can't really comment on the antitrust factor. But what were your thoughts, Richard, on that?
Yeah, I think, to me, if pricing is the primary thing that we're looking at, that it ends up really being kind of a race to the bottom from a pricing perspective, and that's really damaging to providers. And so what we want to have is all of those elements being brought together. And that's really the way to preserve economic value here for providers so that they can continue to be viable and serve their communities.
I think there is a long question related to drugs within the MRFs. I'm trying to read it all.
Let's see. I see one about as part of the year-end audit. And so, yeah, the answer to the year-end audit piece of it is your financial statement audit is not directly related to this. So the annual cycle that you use for your financial statement year-end could be different from what you're using for posting files. And whoever's doing your financial statement audit will not be necessarily looking at this. That's not part of that role generally. And so, yeah, I wouldn't expect this to be tied really in any way at all with your annual financial audit.
I think the question related to the drug standard charge in the machine readable files, because there's so many NDCs and so many different brands and so many different strengths, right? For drugs, how do you actually have this standard charge when there's literally different pricing for the same drug, generic versus brand?
Yeah, there's no question. Yeah, the drug piece of it could well get to be just incredibly complicated, right? So, we all know that the NDC, when you look at the 11-digit NDC code, you not only have the actual drug and the manufacturer, but you have things like, package price and things in there too. So, there's so many different variables, and getting that information in a way that is going to be, something that's reflective of what CMS is asking for here is going to be a really big challenge, I think, for a lot of providers. Because that's just so different from what people are doing today, and they really are looking for all that detail. Let's see, were there any other questions? Yeah, the 340B. Yeah, I think this doesn't have a direct impact on 340B, but yeah, absolutely. The 340B is another concern just generally. It all does kind of tie together here. All right. So with that, I think we've addressed at least many of the questions. For those that we haven't addressed, we will follow up with you guys via email. And apologize for the earlier technical issues. Hopefully we get that sorted out. For follow-up here, we've got some resources. So we've got a link to our healthcare content hub. We've got some great events coming up, so you can see our website. We've got some other webcasts and things coming up. And we do have a great conference happening in Las Vegas, November 1st through the 3rd. So maybe when the OPPS final rules coming out, we'll see. We've got a lot of great content there. We actually have, here I've got on the next slide, we've got a little bit of detail around who all we've got coming there. We've got Donna Brazil, Carl Rove, and I'm working with a colleague on the future of reimbursement, which is going to be lead into Donna Brazil and Carl Rove. So super excited there, along with Dan Kraft and Bradford Cole. So if you are interested at all in some of these big picture issues, we're going to have a great conference and I'd love to see you guys there. And I think that's all we've got.
Yeah, I'd love to see our audience actually coming to the conference and meet Richard and pin him to the wall and ask him more questions about the November, the OPPS rule that's been finalized. Yeah.
All right, yeah, and there's our contact information. So yeah, feel free to reach out to either of us anytime if you've got any questions or would like to discuss further. So with that, I think we're done. I appreciate it, everybody.
Thank you so much for coming in today.
Thank you, Richard and Mandy, for a great presentation today. I also want to thank the audience for being engaged and submitting your questions to help guide today's conversation. If we didn't have time to answer yours, like Richard said, we will follow up with you after the webcast. Also, feel free to reach out to the presenters if you have additional questions. You can find their contact information in the slide deck and on your console. There are a number of additional resources in the upper right-hand corner of your user console that may be of interest to this audience, so definitely check that out. If you met all CPE requirements, your certificate is available to download now in the CPS progress window. A copy will be emailed within 2 weeks should you have any difficulty downloading it now. As a reminder, if you attended today's presentation in a group and would like to receive CPE credit, you must complete the group attendance sheet found in your console. And finally, here is a link to the online survey for today's presentation. We're always appreciative of any feedback that you'd like to share in order to guide future content and webcasts for you. Thank you for joining our webcast, and we hope you'll join us again next time.